So it's been an exciting year for myeloma and NASH. I say that every year. Every year is truly exciting. What's unique about this year, I would say probably the most practice-changing oral abstract in our world is actually not from active myeloma this time, it's from smoldering myeloma. So the AQUILA were presented by Dr. Demopoulos earlier this morning on Monday, and were just published in the New England Journal of Medicine. And in brief, that was a study of Daratumumab monotherapy versus active observation in patients with smoldering myeloma. We kind of retconned it and went back and looked at patients who have high-risk smoldering myeloma by 2220 by our modern criteria for how we consider high risk. And basically, they randomized those patients to either receive 3 years worth of daratumumab, subcutaneous daratumumab for 3 years versus observation. Unsurprisingly, they found that daratumumab lowers the risk of progression. That's pretty obvious, but the question is that worth it, right? Are you actually changing the natural history of the disease, or how long patients live, or how well they live? And indeed, they met that bar. They found that quality of life was better, or at least preserved, in the patients that got daratumumab, first of all. They found that PFS2 was better. So even after starting frontline therapy for myeloma, the patients who got dara up front still did better. And most importantly, and this is the kind of holy grail of smoldering myeloma treatment, they found a survival benefit. So they found that instead of waiting until someone gets active myeloma and giving them 4 drugs then, or typically 3 drugs in that study, a triplet regimen, and transplant, and all of this stuff when they get myeloma, if you intercept them and give them daratumumab now for 3 years, fixed duration therapy, we actually see an overall survival benefit. Patients are living longer and living better. So I would argue that is very practice changing. Of course, daratumumab is not approved anywhere in the world for smoldering myeloma, but the company that makes it has already kind of submitted it for authorization. Once it's there, I will say absolutely will be practice changing. I will recommend this for all of my patients to kind of think about, probably as a default, if they have high-risk smoldering myeloma, again, because there's a mortality benefit. The one word of caution I would say is that this particular study, they did a good job of excluding patients with active myeloma. Prior studies of this same concept of intercepting a smoldering myeloma have really been hindered by that topic of, what if some of these patients had active myeloma and you were actually undertreating them by calling a smoldering? Here, everyone is required to get a PET CT or MRI or something along those lines to rule out active myeloma. So that would be a word of caution. So when daratumumab gets approved for high-risk smoldering myeloma, before you start it, stop. And make sure your patient does not have active myeloma. You need to do a PET CT scan, ideally a PET CT scan and a whole body MRI, to really be sure you're not missing that. Because if they have myeloma, they should be getting myeloma induction therapy, like a quadruplet or Dara-RD or something along those lines. If they do not, though, daratumumab I think is very appropriate.
AQUILA trial is being presented by Professor Demopoulos. This is a phase 3 randomized study comparing daratumumab monotherapy versus observation in patients with high-risk smoldering myeloma. What has been clearly borne out in the trial results that will be presented at this ASH is that giving daratumumab as monotherapy delays progression patients with high-risk smoldering myeloma to active myeloma. So the primary endpoint of this trial has been met, but we are waiting to hear more about the side effects with daratumumab, short-term and long-term in this particular trial. And also what's of interest is a long-term follow-up which will come out later in subsequent conferences as to whether this means that there is an improvement in overall survival in these patients.
When I'm asked what to keep my eyes on for multiple myeloma in 2025, I'm not really sure how to answer that question. I think, first of all, we need to have a lot of eyes because there is so much change going on in the field. I would say this ASH 2024, I was the chairman for a symposia focusing on newly diagnosed myeloma. I reviewed all the abstracts in the database in preparation for this symposia. I found 40 presentations just on newly diagnosed myeloma, and 10 of these were oral presentations. And I also looked through the relapse refractory, and I looked through the biology abstracts, and there are hundreds of them, of course, for those settings. So I think newly diagnosed, we should really keep on looking at. I think there is the evolution of new groups of patients. And what I mean with that is that we historically had the transplant eligible and the transplant ineligible. But as the therapy gets better and better, the immunotherapies are coming up earlier in line. What I saw at ASH is the very rapid development of transplant deferred as a new group. And I was jokingly saying, what is transplant deferred? Is that patients who don't want a transplant, but the doctor is a transplant doctor? Is that what it is, or is it something else? And I think in my clinic, I see more and more patients are questioning the use of old school chemotherapy and looking for these immunotherapies. So whatever our opinion is about that, the data, I think, continues to show that the gap gets closer and closer, and the age discrimination to not have something good to offer patients that are, say, 70 years or older, that's changing. We can give great therapies, and we can offer patients that are both older and younger very good therapies, and they can have very high rates of MRD negativity with great clinical outcomes. I also think that there is a lot of focus on minimal residual disease detection, and that is obviously a measure of the success. In 2024, ODAC voted 12-0 in favor for MRD as an early endpoint for accelerated approval for drug development. So I think that's a huge step forward for the field. I was part of this work, and I worked on it for over 15 years. I think we need to keep an eye on early drug development. I think there will be many more drugs developed in the field for these reasons. And I think the timeline for drug development will continue to shrink. So we probably saved at least 10 years by introducing this new endpoint. So I'm really very excited about newly diagnosed advances, MRD testing, early drug development. And I think that we really have a shot on goal for developing curative treatments for myeloma. That's amazing.
Well, I think one of the things we've seen presented here that's really exciting is the early studies, or the safety run-in kind of, or early dose-finding studies of the induction regimens evaluating CD3 BCMA-directed bispecifics in combination with lenalidomide, Velcade, Dex, or similarly those types of bispecifics in the maintenance setting, either alone or in combination with Revlimid. I think the emerging finding from these is that there are very deep initial responses with unprecedented MRD negative rates. And I think as these studies continue into their randomized formal phase 3 portions, we should look out to see some of these initial results that will hopefully help us identify additional sort of signal for durable MRD negativity and our ability to attain durable MRD negativity with these new T-cell redirecting therapies that we have available to us.